Good morning, Emeritus Chairman, sir, Vice Chancellor, sir, Superintendent, my colleagues, and dear students. A very small and brief introduction to my department. We all know we stand tall so far as vision and the mission of Mahatma Gandhi has been to take the best possible care in whatever means, ways we can, in way of safe, secure, and cost-effective, hassle-free treatment. So far as my department is concerned, we are trying and doing our best to give the safest possible products, which are of high quality and with various improving parameters like NABH and various accreditations we take forward. This is the journey. It all started in 2001. We had our first transplant immunology lab in 2015. NABH, again the first in Rajasthan, and we participated in Placid clinical trial by ICMR. The NMC granted us 2 seats in MD. Now we have 2 batches till now. We have recently qualified for NABH as well, and we are into various treatment modalities, peripheral stem cell collection and CAR T cell therapy. This is a very small department with 2 seats, and now we have just 1 registered PhD student independent of the routine protocol, and also MSc and BSc in. These are the various services available. We have to prepare all these products in the department, and the qualities are checked. Various tests are done in the department before supplying the blood. The various services of which we are going to talk today is the therapeutic plasma exchange. I would like to share the first one was done way back in 2007. I went to MGH Boston, and the case I saw was of a pregnant female, full term, but suffering from multiple myeloma. Now that was the time when I realized it's doable. So till date we have done 444 cases. The various other services, double cascade, leukapheresis, intrauterine transfusions, and peripheral blood stem cell collection, these are all being done in the department. These bloods and products are irradiated before transfusion. The last is the phenotype matched. These are various accreditations imparted to us: NABH, AABB, and hemovigilance. With this, I call upon Dr. Jaiswal also. Please come forward.
Thank you, ma'am, and very good morning to respected Emeritus Chairperson, sir, Vice Chancellor, sir, Sir Deva, sir, and Medical Director, sir, Hemant, sir, and all the distinguished colleagues are sitting here. As Madam told, our journey started way back in 2001 when we got the first license of the whole blood, and in 2012 we got the license of platelet pheresis, and we started preparing our component. I'm not going to repeat. These are the various achievements of department where we achieved first time either in state or in India. So it was the first blood center in Asia who received quality certificate from American Association of Blood Bank, and was the first blood center medical college in Rajasthan who received NABH accreditation. And we are proud to say we are having 3 dedicated hemovigilance nurse in the India. First one was the PGI Chandigarh, second was the Sri Ram Chitra in Chennai, and third was our Mahatma Gandhi. Then blood center of state, because all the transplant related activities has to be with the NABL accredited. So this was the first lab and only lab till date in the state of Rajasthan which is NABL lab for testing all the organ transplant activities. And we also did first harvesting of CD3 cell for CAR T3 cell, And we are having various international collaborations with the international organizations. This is the University of Alberta, which is one of the prominent centers in the globe. And recently we got a project from the European Union to promote transfusion education across the global, and the project name is the Transmed Africa. Only two universities from the India is selected. One is the Manipal and second is the MGUMST. We also detected various novel allele, and that was recognized by the WHO nomenclature committee, and this was already published in Transplant Immunology journal. Because this is a novel allele, when we are doing any kind of testing, so we have to report to Anthony Nolan Center. Anthony Nolan is one of the biggest registry for bone marrow transplant across the globe. So we have to submit our data, they verify, and then they give nomenclature of by WHO. So these are the two novel allele which already submitted, and they give nomenclature to these novel allele. We also, our department is actively involved in various research, innovation and extraction activities. We received grant for ICMR for Placid trial, and as I already mentioned, we recently got a grant from European Commission for Transmed Africa project, and we also received various intramural grants for COVID-19 study. We are one of the major center during COVID time, and we got the request across from Kanyakumari to Kashmir for COVID plasma, and we fulfill all the demands at that time. And thalassemia mutations, this is again one of the very hot topic, and under the leadership of Dr. Rachna ma'am, we started various projects on thalassemia, not only for the diagnosis, even for the stem cell transplantation is already going on. And we also received more than 5 international TAVN grants to present our paper and poster to various by international societies. More than 150 international conferences, seminars attended by our department colleagues, and we organize 14 conferences, including international and national conferences. We time to time we are organizing various workshops on HLA, flow cytometry, and hemovigilance. Hemovigilance program is initiated by the government of Ministry of Health and Family Welfare. They organized one workshop in our institute. These are the various photographs. Last year we organized National Conference of Ishicon and visiting of different reputed centers across the globe. Publication profile from our department, more than 50 articles has been published, and we presented more than 22 papers in various conferences. We involved in clinical trials. A few of them we also involved in the dendritic cell vaccine project and some other clinical trial, because blood center is one of the manufacturing product for the mononuclear cell, which is one of the raw product to develop any kind of vaccine. Chapter published 2, and more than 900 citations are already registered to in name of our department. These are the few example of various papers. Recently our resident got first best paper poster award in a conference held in Mumbai, and fortunately Hemant sir was there and he posted these photos, and it gives immense pleasure because our students are recognized globally and nationally at different platforms. And faculty serving in national and various international committees. We are the part of the cellular therapy, patient blood management, Asia Pacific groups, subsections of various societies. We are also serving chair of international committee of the American Society of Histocompatibility and Immunogenetics, counselor for OFIA, and reviewer of high impact international journals. These are the various membership from our department. And our main strength, because we are blessed to have management like we are having, because whatever we require, the management of top management of MGUMST is always willing to provide us, and that's why this is one of the important reasons why we are able to give so much work and involve in various research activities. Dedicated team, efficient and trained supportive staff. Advanced immunohaematology is one of our strengths. NAT lab is our strength. Transplant immunology is again one of the strengths of our department. And Safe Trans software, which is presently we are moving toward paperless hospital. So we are already using this software since 2021, and I am very proud few departments are 100% using this, and by using this software, there is no need of a movement of papers. We can give right product on the just like a mobile app. These are the various important sections of our, and we are also doing electrophoresis for all the blood donors, and we also started thalassemia screening for all the antenatal patients, and we proudly say, sir, we screened till date 700 to 800 samples, and we found 3-4 cases which are thalassemia. They are not aware of their thalassemia status. That is, of course, yeah, and that is a completely free of cost. And just because of the approval from the top management, and we are giving free thalassemia screening for all the patients who are attending our antenatal clinic at Mahatma Gandhi. These are the some donation and issue statistics of last 5 years. In 2021, we collected near about 6,000 blood unit products. When we are comparing in 2024, that is the last year, we collected near about 14,000. Our workload is triplicate in due timeline, and these are the various activities. These are the important statistics. Apart from that, we are also involved in special procedures, TP, granulocyte, and PBSC, and day by day number is increasing. Initially, in 2021, we are comparing data. We are doing 15,000 blood group. When we are comparing with last year data, right now we are going to touch 50,000 tests in a year. So this is the huge workload in our blood center, and our team is so efficient, is catering very well. These are the HLA test and flow cytometry and other important data. And this is the screenshot of our Shoto state organ website, and out of 49 cadaveric donation happened, disease donor mentioned their website, and out of 49 we performed test in 44. That is the near about 90% of tests we have conducted here. These are the various media coverage of our department, and this is the outreach activities, and the highlighting of our institute in the Hemovigilance newsletter by National Institute of Biologicals. These are the various certificates: American Institution of Blood Bank certificate, and NABL certificate, and Hemovigilance certificate. And we also celebrated various days, especially Thalassemia Day and World Blood Donor Day. And this is the our screenshot of software. We are aligning department objective with the organization goal. So just my sincere request to all the stakeholders, please utilize this software as much as possible. So just like Amazon, you can get all the details in a real-time manner. And our department future plan is to Center of Excellence for Hemoglobinopathies, extracorporeal photopheresis, because we are one of the leading center of oncology. So most of the time for the GVHD, this is a very important instrument, and Clinimax for cell and gene therapy, and universal pathogen reduction. And apart from therapeutic plasma exchange, we also conducted therapeutic procedure for thyrotoxicosis, neuromyelitis optica, hyperleukocytosis, and to reduce donor-specific anti-HLA antibody before transplant. We have done especially in 2 cases, and essential. These are the, just I would like to emphasize before beginning the main case, therapeutic plasma exchange is not a definitive treatment, it is just a supportive treatment. So in view of that, I am going to invite our Dr. Naveen Choudhary from the Department of Medicine to take forward. Thank you very much.
Good morning, Honorable Emeritus Chairperson, sir, respected President Vice Chancellor Dr. Achal Gulati, sir, senior faculties, colleagues, and students. Myself, Dr. Naveen Choudhary, second year general medicine student, will be presenting today CCR under guidance of Dr. Puneet Rijwani, sir, and Dr. DP Bansal, sir. So, starting with the case. A 36-year-old married female housewife, resident of Churu, Rajasthan, presented with chief complaints of fever with chills, multiple painful itchy lesions involving both the upper limbs and face from last 3 days, difficulty in swallowing, foreign body sensation in the both eyes, and oral ulcers from last 2 days. She was asymptomatic 3 days back when she started developing fever, which was sudden in onset, progressive, continuous, high grade, and relieved on medication. She had multiple painful reddish brown lesions involving both the limbs, face, and neck, with severe itching and pain. Pain was of burning type throughout the day, non-radiating, with no relieving factors, and there was crusting present over the lips. She also had multiple painful erosive oral ulcers over tongue, lips, gums, and base of palate. with difficulty in swallowing more to the solids than liquids. She had severe itching and foreign body sensation in both the eyes with intense watering. Talking about negative history, there was no history of shortness of breath, cough, chest pain, loose stool, vomiting, pain abdomen, burning maturation, increased frequency of maturation, and decreased urine output. No history of any joint pain, no history of any insect bite or topical application in recent. She underwent brain surgery for astrocytoma grade 4 in January 2025 at our hospital and completed adjuvant treatment as advised and was asymptomatic after that. She was on multiple anti-epileptics since last 2 months before developing the rash. She was on tablet phenytoin, tablet levetiracetam and tablet sodium valproate. She had no history of any comorbidity. No history of similar complaints in family. Normal menstrual cycle of 28 days with 4 to 5 bleeding days with normal flow. Vegetarian by diet, non-smoker, non-alcoholic with normal bowel and bladder habits. No drug addiction with normal sleep cycle. To summarize the case, a 36-year-old female, operated case of astrocytoma grade 4, after completing adjuvant treatment, was on 3 antiepileptics since January 2025, presented with high-grade fever and chills, multiple painful itchy skin lesions and oral ulcers from past 3 days. Now I would like to ask the audience about the possible causes for the patient based on the history. Okay.
Or also we can, if there was a history, long history, then we should think about the vesicobullous disorders, autoimmune disorders.
Okay. Thank you.
So secondary to what? Steven-Johnson or toxic epidermal necrolysis? Secondary to?
The most common drugs which can cause Steven-Johnson syndrome or toxic epidermal necrolysis is anticoagulants, then the antibiotics, beta-lactams, NSAIDs also are mostly, and phenytoin.
So in our patient was taking anti-epileptics.
Yes, sir.
So one of those drugs could have been responsible. Any medication she took for fever? So like the 3-day fever, paracetamol or antibiotics?
She didn't take any medication before developing the symptoms. But when she presented with us, she was not on any medication.
And the surgery and the radiotherapy was concluded when?
Sir,
for the brain tumor?
15 days back it was completed.
Only 15 days
Yes,
back.
sir.
Okay.
Based on the above history, these can be possibilities, which are Steven-Johnson syndrome, toxic epidermal necrolysis, erythema multiforme, fixed drug eruptions, staphylococcal Skilsane syndrome, pemphigus, and bullous lupus erythematosus. On general physical examination, patient was conscious, oriented with average build, no evidence of pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. Her BP was 126/82 mm of mercury with pulse of 102 beats per minute, regular with normal volume, normal character. All peripheral pulses were felt. She was febrile when she presented with us with fever of 101.2 degree Fahrenheit and saturation of 96% on room air. On local examination, multiple discrete to confluent dusky erythematous macular lesions were present over face, neck, chest, back and bilateral upper limbs. On systemic examination, all systems were in the normal limit and investigations were sent. On day 1, her hemoglobin was 10.3 with TLC count of 14,800, neutrophils of 81.6, ESR of 24. PBF was suggestive of neutrophilic leukocytosis with microcytic hypochromic anemia and platelet count within normal limits. Renal function tests were within normal limits. Liver enzymes were mildly raised, double the value of normal limits. Patient was started on IV empirical broad spectrum antibiotics, that was ceftriaxone and clindamycin, NSAIDs, fluid therapy and supportive measures. Despite above treatment, she remained febrile and lesions were rapidly progressive, and she was shifted to ICU for isolation immediately. Dermatology consult was requested for their expert opinion. Now I would like to invite Dr. Akshit from Department of Dermatology to take this case forward.
Thank you, Dr. Naveen. Good morning to everyone. Myself, Dr. Akshit Yadav, will be taking the case further. So we were referred a patient, a 36-year-old female from the Department of General Medicine with complaints of painful itchy lesions, which were present for the last 3 days. So on examining the patient, we found multiple discrete to confluent dusky erythematous macular lesions over face, neck, chest, back, and both the upper limbs. There was peeling which was present over the back and the right arms, and there were multiple erosive lesions which were present over the lips, perioral region with adherent hemorrhagic crusting. So coming to the mucous membrane examination, there were oral examination, there were multiple ulcers present over the buccal mucosa, and on ocular examination there was conjunctival injection present, and the genitalia was spared. On palpation there was a pseudo-Nikolsky sign which was positive. What is that? Sir, we apply lateral pressure to the skin, and the epidermis slides over the dermis, sir. So the provisional diagnosis which was given was this Stevens-Johnson syndrome or toxic epidermal necrolysis, secondary to phenytoin, query phenytoin of sodium valproate, which was based on widespread erythematous macules with epidermal detachment, mucosal involvement which was severe, more than 2 mucosal sites, and a pseudo-Nikolsky sign which was positive. And the skin biopsy was sent for confirmation. So treatment was advised, which was stop all the suspected drugs. Injection dexamethasone 8 mg IV 12 hourly. Capsule cyclosporin 200 mg in the morning and 100 mg in the evening. Topical steroids and antibiotics, and supportive care. Now I would like to invite Dr. Naveen to discuss the further treatment.
Thank you, Dr. Akshit. Despite above treatment, patient condition deteriorated and treatment modalities were reviewed on day 5 of admission. The available treatment modalities are: first is systemic corticosteroids. Its use is very controversial. Older studies didn't favor the use of corticosteroid, but newer studies suggest that it can be used in systemic corticosteroids for a shorter duration, as it increases the risk of secondary infections and delayed wound healing. Second was cyclosporin. It inhibits the activation of CD4 and CD8 T cells in the epidermis by suppressing the release of interleukin-2 release by the activated T helper cells. Third is intravenous immunoglobulins. It blocks the fast ligand mediated keratinocyte apoptosis. It is used in mild to moderate TEN. Employed with some success, but the high cost of therapy makes it less favorable option amongst them. Fourth was therapeutic plasma exchange. It can be used in refractory TEN, as in our case. It removes the circulating fast ligand, cytokines, and drug metabolites. Fifth was tumor necrotic factor alpha, but it has a lack of evidence, and research studies are going on.
Thank you, Dr. Naveen. Good morning. I am Dr. Sankalp from Critical Care Medicine, and I'm going to take this case forward under guidance of Dr. Ashish sir and Dr. Ravi Jain sir. So a 36-year-old female with past history of astrocytoma grade 4 post-op, post-radiotherapy, who was on anti-epileptics. Patient was kept in isolation and strict reverse barrier nursing was maintained. Paraffin gauze and collagen sheet dressing was done. Saline compresses and lubricant application was done. So any patient who is admitted under our ICU, we use this ICU care bundle, which has the mnemonics of fast hugs bed. This bundle ensures comprehensive high-level evidence and evidence-based care across multiple parameters essential for critically sick patients. So we initiated feeding, early enteral feeding on day 1 itself, adhering to the nutritional targets of 20 to 25 kilocalorie per day. Patient was counseled about the procedure and proper written informed consent was taken. we introduced a hemodialysis catheter, double lumen catheter line of size 13.5 centimeter that was inserted under ultrasound guidance in the internal jugular vein. Therapeutic plasma exchange was initiated as planned by the Department of General Medicine and Department of IHBT. A proper chest X-ray was advised after insertion of the line. So to discuss about the therapeutic plasma exchange, I invite Dr. Nisha Raj from the Department of IHBT.
Thank you, Dr. Sankalp. Very good morning to respected faculty members present here once again. I am Dr. Nisha Raj. I am a second year resident in the Department of IHBT, and I will be taking this case forward from here. But before I take this case forward, I would like to highlight two words over here. That is, the first thing is plasmapheresis, and the next word is TPO, or therapeutic plasma exchange. Many a times in our setting we are using these words interchangeably, but I would like to specify both these terms define two completely different processes. So plasmapheresis is where we are collecting plasma, and a very good example is collection of COVID convalescent plasma. And in therapeutic plasma exchange, or TPE, we are actually removing the plasma from a patient and replacing it with a replacement fluid. So as we move forward with the case today, just to summarize very shortly, we have a patient. She's a 36-year-old female, and she's having these extensive skin lesions, and she's having fever. Initially she was being treated in the ward, and now she has been shifted to the ICU, and we received the reference from the Department of Critical Care, and then a collective decision is made along with the Critical Care Department, the Medicine Department, and the IHBT Department that therapeutic plasma exchange may be done for this patient. So what is therapeutic plasma exchange? Therapeutic plasma exchange is a process in which we are removing the plasma of the patient, and we replace that removed plasma with a replacement fluid, and we return the other cellular components of the blood to the patient. Now when the process happens, when the TPE or the therapeutic plasma exchange happens, multiple things get removed with that removed plasma. That includes antibodies, that may be autoantibodies or alloantibodies, drug metabolites, toxic metabolites, and immune complexes also get removed during the process. Now why would we want to do a therapeutic plasma exchange in this case? The reason is because in severe cases of Stevens-Johnson syndrome, toxic epidermal necrolysis, especially when there is extensive skin detachment, significant mucosal involvement, or when other treatments have been shown to be not effective, we should consider TPE. And we know that Stevens-Johnson syndrome and toxic epidermal necrolysis is T-cell mediated, with immune complexes and inflammatory mediators playing a role in tissue damage. So the TPE aims to remove these harmful substances from the blood, potentially mitigating the inflammatory cascade and reducing tissue damage. And TPE is typically used alongside other supportive care measures like wound care, fluid management, and pain control. Whenever we do therapeutic procedures like this, we follow the ASFA guidelines, that is the American Society of Apheresis guidelines, which has classified 91 diseases with 166 indications, which have been grouped into 4 categories and 2 grades, and toxic epidermal necrolysis falls under category 3 and grade 2B. Now how does this work? So we need to understand that our blood contains the cellular components and it has the fluid component, and each component has different specific gravity. So when the whole blood is passed into the centrifuge, the layers will form based on their specific gravity. That means the lighter layers will form the upper layer, and the heavier particles will settle down and form the lower layer. That means plasma, being the lightest amongst all of this, forms the topmost layer, and that is how we are able to identify the desired layer, and it is removed through the machine. Now a special procedure requires special equipment. So the equipment that we are using the Comtech machine. It is from the company Pharmacology, a multi-purpose machine. It can be used for multiple procedures like collection of stem cells, collections of granulocyte, collection of single donor platelet, and along with that this machine can also be used for therapeutic plasma exchange. How does it work? So basically it draws the blood from the patient, An anticoagulant is mixed with the drawn blood and it passes into the machine centrifuge, and as I had discussed, the layers are formed in the centrifuge and the desired layer, that is the plasma layer, gets removed and gets collected into the waste bag, and the remaining constituents of the blood are returned to the patient along with a desired replacement fluid. Now, what are the kinetics of this plasma exchange? So when we are deciding to do a plasma exchange for any patient, we need to take few points into consideration, and the first point is fluid balance. That means we need to decide how much of plasma is to be removed, and at the same time we have to replace that plasma with a replacement fluid so that the fluid balance is maintained. The second thing is we need to decide the volume of plasma to be removed. We have to decide the frequency of the cycles and how many cycles need to be done. Along with that, uninterrupted blood flow is required for optimum results of the patient, because the outcome of the patient is relative to the plasma volume that is being exchanged or processed. The amount of the desired material that we want to remove from the patient, whether it is present in the intravascular compartment or whether it is present in the extravascular compartment, and this desired component that is being targeted to be removed, what is its mobility between the intravascular component and the extravascular component. Next comes our prerequisites and procedural considerations. So once it has been decided that okay, now therapeutic plasma exchange needs to be done for a particular patient, we need to get the blood grouping and antibody screening done for this patient. The weight and the height of the patient is noted. This patient requires hemoglobin levels of at least 7 gram per dl, a hematocrit of at least 20%, and a platelet count of at least 50,000 before we initiate the procedure. The ionized calcium, the serum electrolytes and proteins should be in the normal limit. Along with that, as I had previously mentioned, the central venous SS is required because we need uninterrupted blood flow, and we prefer the double human hemodialysis catheter for this process. Replacement fluid is decided, which replacement fluid we are going to use. Along with that, anticoagulation is required. We take a detailed history of the patient and we take informed consent from the patient or the patient relatives. This is a form that we receive from the department when we receive the request for the procedure. With this duly filled and signed form, we receive 2 samples of the patient, and this is a picture of our informed consent that we are taking from the relatives of the patient. Now, the next step is calculation of the plasma volume to be removed. So the efficacy of a plasma exchange is related to the amount of plasma that is removed. So a procedure that removes the plasma equal to the patient's plasma volume, it is known as a one volume plasma exchange, and it is expected to remove at least 30% of the unwanted constituent. But subsequent plasma removal removes only 10% of the unwanted constituent on double or triple volume exchanges. That means if we process double volume of the patient's plasma or triple volume of the patient's plasma, we will not get any benefit, rather only 10% of the unwanted constituent will be removed. That's why guidelines have stated that we should remove at least 1 to 1.5 total plasma volume during each cycle. The next step is selection of a desired replacement fluid. So the available replacement fluids with us are albumin and fresh frozen plasma, or a combination of albumin and fresh frozen plasma. Now the choice of the replacement fluid of a TP depends on the individual's patient's condition, the underlying disease and the potential risks and benefits of each fluid. So albumin has a lower risk of adverse reactions when it is compared to fresh frozen plasma. It has less risk of transfusion related complications and allergic reactions. It is easier to store and administer, and it is generally well tolerated. On the other hand, fresh frozen plasma, although it replaces plasma proteins, it replaces coagulation factors, it always poses a high risk of transfusion related complications such as allergic reactions, and it requires blood cross matching. Now for a patient who is already suffering from extensive skin lesions, administering fresh frozen plasma as a replacement fluid would not be a choice, because it is only going to aggravate her problem in case it causes an allergic reaction. Hence we selected albumin as the replacement fluid here for this patient. Next come some calculations that we do. So we need to calculate the total plasma volume of the patient, and this is done by the given formula that is given on the screen. This is the procedure that we had, a bird's eye view of the procedures that we had done. So a total of 3 therapeutic plasma exchange was done for this patient. All the procedures were done on alternate day in the ICU setup, and the selected replacement fluid was albumin for this patient. And now we will see how this patient progressed during each cycle. So after the first cycle, we saw that no new lesion appeared. That means the rashes, they became, there was no progression in the rashes. Next, after the second cycle, we saw that the present lesions, they started to heal, there was dryness, and then the mucosal secretions had also significantly reduced. And after the third cycle, we saw that wound healing and reepithelialization was evident, and hence we decided that now no more future cycles are required, and then the patient was transferred to the supportive care. Now, we started from a patient who looked like this. There was extensive lesions. This patient was having lesions on her face, her back, her chest, hands, etc. And she was treated in the medicine ward, then the ICU, undergoes 3 cycles of therapeutic plasma exchange, and finally, before this patient gets discharged, this is how our patient looked. Her wounds had healed. So the recovery of this patient is because of the collective efforts of all the departments that were involved. And thank you, sir. And now I would like to invite Dr. Parthil. He is from Department of Pharmacology.
I'm Dr. Parthil Patel from the Department of Pharmacology, second year PG resident. I will present pharmacovigilance aspect of this case. As we can see here from the table, the list of drugs were prescribed by the neurosurgeon after the astrocytoma surgery on 30th January 2025. After that, patient came to hospital after 2 months with and first adverse drug reaction was reported on 29th March 2025. So based on these drugs, phenytoin was our primary suspecting drug. Apart from that, sodium valproate with the combination of valproic acid and ibuprofen with the combination of paracetamol were the other suspecting drugs. These all 3 drugs most likely to cause severe cutaneous adverse drug reaction, which is Stevens-Johnson syndrome or toxic epidermal lytic necrosis. Apart from that, cefixime, omeprazole with the combination of domperidone, amlodipine with the combination of olmesartan, hydrochlorothiazide and levetiracetam were prescribed, which are concomitant drugs not likely to cause adverse drug reaction. Based on WHO Uppsala Monitoring Center criteria, we perform causality assessment on suspected drug, and based on assessment criteria, temporal association, which means timely relation after the drug first administered to the first adverse drug reaction happened, which was onset after 2 months, consistent with the phenytoin-induced Stevens-Johnson or toxic epidermal necrosis syndrome. Non-adverse reaction apart from phenytoin, there is a possibility of ibuprofen or valproate. D-challenge was performed. After the withdrawal, drug symptoms were improved, and re-challenge also performed. After the patient discharge, similar medication was prescribed to the patient and no ADR was reoccurred. Alternative cause can be a timeline favor other drugs or delay immunological response. And based on previous literature, most of Stevens-Johnson syndrome or toxic epidermal lytic necrosis occur within 8 weeks. It might be can after the 8 weeks. So based on our evaluation, the reaction categorized as a possible, which timely fits well, and other possible cause can be present with this patient. These are the adverse drug reaction were filled up by the hospital and submitted to ADR monitoring center. Now I would like to call IHBT department for review of literature.
So I have a question to medicine and dermatology. Can you make a diagnosis just on the clinical syndrome, or is a biopsy essential? We didn't talk about a biopsy in this.
The biopsy was proven. They sent, but because of time limit, we not involved here. A biopsy was sent and biopsy was confirmed proven by the time. Okay. But our first priority in this case to alleviate the symptoms. And as already mentioned, apart from the drug monitoring, there is a different type because we are aware of this patient might be have phenytoin-induced tan or JS. So we did HLA typing of this patient. And for the academic interest, we did HLA typing, and what we found one of the allele of HLA-B, that is the 5101, that is having genetic predisposition of phenytoin-induced tan. And when drug is associated with a genetic predisposition, toxicity level may not work, because in minor dose patient may get these kind of reaction. So just for academic interest we did, and we found. And apart from that,
you mean they are susceptible for the familial?
Yes, sir. Yes.
So does that follow the Mendelian law, or is it a sort of chance?
So this is follow Mendelian law, sir.
Dominant and recessive.
This follows the Mendelian law. Yes, sir. This follows Mendelian law, especially all the HLA allele which possess to genetic, and this is a good practice if we screen all the patient relative for the possibility, because it is a high chance the patient relative may carry these kind of alleles. So we should avoid these kind of drug in that particular patient. This is not the first case. Previously, last year we also got this similar type of case, and we did HLA typing, and we found that was associated with the HLA.
Did you do for other family members?
Sir, we not did, but ideally it should be done, because the test cost is 16th. Again, for the academic interest, because we are aware of there is a high chance we may get this allele, so we did this and we found that. And then we searched the literature, and there was in South Indian, especially in Tamil population, this is the high incidence when 5101 is associated with phenytoin-induced drug reactions. These are the other supporting measures. These are pharmacogenetic biomarkers. There is a list of drugs which can cause adverse drug reactions, and out of these, phenytoin HLA-B 1502 and 5101 both are responsible for this kind of reactions. And drugs other than phenytoin, just like a carbamazepine, it is a very good practice if we are going to prescribe, but again the cost benefit analysis is required in that. Carbamazepine is associated with the 1502, is most of the time they are highly responsible for SJS, and on the basis of this paper we can see the sensitivity in the last corner. The sensitivity of the drug association, especially in phenytoin, is nearly 20%. And this study not in the Indian population, this study done in the Thai and Chinese, because this article from the Japan. So we 100% sure that this is the phenytoin was the main culprit. Apart from the biopsy, we proved that this is a high chance. And apart from that, when they remove the drug, the symptoms reduce. And when we are doing TPE, to alleviate the system within a 72 hours to 96 hours, we got a very good result, because what the immune complexes develop because of the drug we removed, and patient heals very rapidly. So this is the effectiveness of early treatment. TPE, if we intervene early treatment by TPE, we get very good cases, very good results. And there are various articles which support therapeutic plasma exchange in these type of cases. And apart from that, if therapeutic plasma exchange is an effective modality, not for SGS, we are using for various cases for autoimmune, especially GB syndrome, myasthenia gravis, neurological condition, in various hematological condition, and renal disease, because one of the major indication of plasma exchange is ABO incompatible renal transplant or ABO incompatible liver transplant. Time matters, and early initiation lead to better outcomes, and life-saving therapy, especially when guided by appropriate indications, early interventions. And yes, we are blessed with having very good team here, so that we discuss this case in a very timeline manner, and we initiate treatment as soon as possible. And by this, just I want to thanks and acknowledge the contribution, and special thanks to management of MGUMST, because these all kind of treatment and research is only possible of what kind of infrastructure we are having. And it is very proud to say we are one of the unique department, not only in the state, even in the country, which are giving so many tests under one roof, and this reduces a lot of time burden and immediate integrated approach. Just like we are having HLA typing, we immediately did HLA typing, and we got the correlation, very good result. And thanks to Department of General Medicine, Department of Dermatology, Venereology and Leprosy, Department of Critical Care and Department of Pharmacology, and my special thanks to all the members of CCR Review Committee. Thank you very much.